My interest in health equity and policy actually started very early on when I was a kid. So as a child, I watched my family members, older family members, over time lose their abilities due to chronic diseases like diabetes and heart disease and cancer. They lost their eyesight, they lost mobility because of amputations. Some of them had strokes. And watching this over time, I asked my family members, my parents, sort of why is this happening to them? They have a regular doctor. I didn't understand it. And their response was, that's just what happens to us when we get diabetes or heart disease, et cetera. And so that made me think about why is it that people who hypothetically have access to health insurance, have access to doctors, would have these horrible outcomes? And more importantly, why are we okay with that? Why is that not something that's being addressed, that's being looked at? And that's really my motivation for a lot of the work that I do.
We're in an extraordinary period right now where there are revolutions in health technology and information technology. But what we're not really seeing is the same sort of progress in advancing access and affordability. And so we're getting this disconnect with incredible technological progress, but we're not really leveraging that to produce improvements in health.
It's very important that the benefits of technology and advances are spread equitably among people. Health equity has always been a major concern, and health disparities have been quite significant in the United States and elsewhere. COVID showed us just how bad that actually is.
I think one of the things that COVID-19 did is it really once again magnified the structural inequities within our healthcare systems and beyond that really drive health outcomes. So for example, in some research that we had done early on, what we found was that your likelihood of being infected with COVID was very closely related to your socioeconomic position and where you lived. Your ability to be able to distance yourself from others, the ability to be able to take a laptop and work from home, all of those are driven by what kind of job you have and income inequalities and other factors that contribute to that. And so what COVID really showed us through those early outcomes were these stark differences in hospitalization and mortality, particularly in communities of color, among Latinx, Native American, Black, et cetera. And a lot of that had more to do with where they lived than whether or not they even had health insurance.
The development of COVID vaccines in record time really has been one of the great breakthroughs in health technology ever. But at the same time, I think it's very easy for us to see where we failed, and that is delivering those vaccinations at scale to a wide swath of the population in a way that's equitable and really kind of capitalizes on their promise.
There are great differences due to socioeconomic status in our country and, in fact, in every other country I've looked at. It's not just in our country, if you're poor, you can't afford medical insurance or medical care, because if you go to Scandinavia, the people who are poor there do worse too. And they have a social safety net, they have healthcare. So understanding why it is, what is leading to people getting those worse outcomes, there's deeper things that are going on that we need to kind of understand what the reasons are for those things.
In the past, for health equity, we primarily focused on healthcare delivery, whether or not people had good access to high quality care. And as important as that is, a lot of the factors that contribute to the disparities that we see actually happen long before anyone comes into a clinic. It really is where you live, where you work, and how you live that influence your outcomes in terms of health. So in order to really make an impact, we have to not only focus on the healthcare system, but all of the other structural and systemic factors that contribute to these inequities.
Part of my mission as a health law scholar is to understand how we use the law as a tool to make things better, but also how we understand areas where the law has actually contributed to problems of inequity in health. There are all kinds of ways in which our healthcare system, for example, has been set up by statute in ways that make access difficult for poor persons and persons of color. And then there are all kinds of non-healthcare policies that have contributed to structural inequities that lead to differences in people's health. Housing policy, education policy, the limited nature of anti-discrimination laws. So we have to identify places where law has been pernicious, do away with it, and at the same time take advantage of the tools that we do have to try to take affirmative steps towards increasing equity throughout our other systems.
When I joined the Department of Health Policy at Stanford, I knew that I wanted to continue centering health equity in my research and in my contributions to the department. It's really an imperative that we have in health policy to focus on health equity. As part of that work, we developed the Health Equity Lecture Series here in the Department of Health Policy, where we focus on bringing leaders from around the country to share with our community and around the world their research in a variety of very important topics related to health equity. This has included pharmacoequity and indigenous data sovereignty. And this lecture series is really a flagship event in the department and the campus where we're contributing to the department's overall mission in innovation and education as it impacts health policy.